So I also, these are my disclosures. I do some consulting, and I have some patents on these. And I am also one of the editors for the Journal of Orthopaedic. You kind of heard just a little bit about the path. I started in Chicago, got to know a team with Galante and Andrianchi in the early days of the Miller-Galante knees, and then the next gens. Then transferred to Boston, got educated there by some of the people who were doing hip and knee surgery, and then I got into design when I was working at MIT, so we began to look at ways of analyzing knee motion and coming up with better designs. I've had the good opportunity of working in several places in the Middle East, the Far East, and looking at different cultures and anatomical variations. And I don't need that. So, I think everybody here agrees, including Dr. Patel, who gave a good lecture on just how this affects the bearing surfaces. And I've always been a believer that the more data you collect and the more you analyze the design, the better off you're going to be. So one of the things that we began to look at was the mobile bearing knees, because they had markers in them and we could see they were fairly free to rotate. And this allowed us to analyze paradoxical motion. I think there's a... So we could see that, exactly as Dr. Patel said, inflection, the bearings were sliding forward, and in extension, they were sliding backwards. So that was paradoxical. It was still accomplishing a form of screw-home mechanism, but for the wrong reasons. And no one really realized that until we came up with this analysis. So based on that, one of my MIT students, Professor Scott Banks at the time, began to look at fluoroscopic analysis. And we began to do image matching because computers had now gotten strong enough where we could look at hundreds of thousands of images to look at high-speed fluoroscopic analysis. And that really allowed us to see what knees were doing and why they were wearing out and why you saw all those tremendous wear that Dr. Patel showed. And this was the concept of image analysis. And this really helped us look at all knee designs and see which one of them had the stability that Dr. Patel just talked about, and which one of them limited motion so much that they did not allow certain things to happen in the knee. So here's an example of both a PS knee on the right and a CR knee on the left. And you can see the basic motions in both of these designs are the same. The kinematics of the knee are not terribly complex on a broader scale, because what has to happen is that the femoral component has to roll outward and grab the patella, which is the quadricep, in the early flexion. And then once it harnesses the patella, it rolls back internally. So there are two pivoting motions going on in the knee. So we began to play with that and look at how we could better design something that had stability but still allowed the motion. And so I was fortunate at the time to be working in Saudi Arabia, where they have the highest knee disease in the world and the most lax and have combined cruciate insufficiency. So we were beginning to try and find a knee that would work in that population where they wanted 150 degrees of flexion and stability. So why do a pivoting knee? It's exactly as Dr. Patel said. You want something that's stable, strong, has a good range of motion, and has lower wear. So pivoting allows you to get those things, whereas the PSD, it provides some of those things, but it also provides increased wear and increased liability of having something happen to that post, either it breaks or it walks over the post if you don't get it balanced right, or the patient flexes past 130 degrees. So again, why pivot the knee? Because the knee has to do two things. It has to roll out and grab the patella and the quadriceps, and then it has to roll back in as flexion increases, which causes the rollback. And so that pretty much leads you to decide there can be two pivot locations in the knee. And whether you start in one position or start the other position doesn't matter so much. What matters is that the design of that bearing surface has to accommodate the pivoting motion of femur rolling out and then rolling back in. So that leaves you with several options. So dual pivot, it provides stability, it provides axial rotation, which makes it a little easier for the surgeon to implant the knee. We figured out you don't really need those mobile bearings, and the mobile bearings really are a liability for trying to control stability. The PCL is another thing that can be played with, and as you heard from some previous lectures, each femur is different, each tibia is different, each patient is different. So having some options when you're in surgery and having a strategy about how you deal with that is important. So that stability, that ability to provide rotational freedom basically dictates that you need pivoting points in the knee. So with that pivot, you'll get the things that Dr. Patel just talked about: better stability, better flexion, better strength. And that's the way the knee should move. So now, if you look at what bearings, if you're the surgeon in surgery and you wanted to have the option to treat, what you were running into as you went through the complexities of that particular patient, then having a variety of choices of how you can pivot the knee makes sense. So you can start out with the pivoting medially, you can go laterally, you can start out laterally, and medially you can do ultracongruent. The major manufacturers now have taken an ultracongruent and converted it into a more pivoting bearing, which makes more sense. It's not perfect, but it does allow for things to happen. So these are some of the geometries that you can have depending on where you start the pivots and where you end the pivots. So after all these years of looking at kinematics of almost every knee design out there, we feel that most of the knee designs can be converted to a pivoting knee with just the right type of articular surface. And there's already a lot of science out there. The next couple of slides, I'll talk about that. This information took us a long while to get out 20 years ago, but people began to understand that, hey, this does work better and the results are better. So we've had several publications over the years. These are a few of them that we've had, starting out in 2014, where we looked at accommodating the absence or presence of posterior cruciates, and then we looked recently why a posted cam really is not any longer needed in the primary knee. It might be needed in knees where you are doing a revision and you need to create collateral ligament stability. So Mike Meneghini has done a couple recent papers with a lot of results in this most recent one in 2024. There's 1,400 knees in that study, and I'll talk about that results in the next slide. But he also had done an earlier paper with 400 or 500 knees showing the optimal outcomes of pivoting knees. So this was the paper I just talked about in 2024. So the dissatisfaction in these patients was reduced by 50% overall, and 25% of the patients felt the knees felt more normal, and these patients also were 2 times more active than the control of a non-pivoting knee. So in conclusion, pivoting knees restore knee kinematics that need to happen. It can be restored in a couple of different ways, where you choose the pivoting points, and each knee is a little different. They're stronger, better range of motion. The wear characteristics are much better. We don't have all the patella problems now that the knee rolls out and grabs the patella. And we have over 20 years of excellent results and information. So this most recent patent allows you to use multiple bearing surfaces with a single femoral component, so that you can choose and pick and optimize the characteristics and the stability of that knee to that patient, so you're actually personalizing the knee. And this is what we wanted when we were looking to get people to do the activities that they wanted to do. This was basically what had to happen. So when you have this ability, then patients become happy. So thank you very much.